Let's talk about the cranial nerves. Now, it's very important to remember which cranial nerves, what their names are, first of all, whether they deliver motor innervation, sensory innervation, or both, and also their major functions. Now, the best way to remember whether they're motor, sensory, or both is with a mnemonic, and the best way to remember the names is with a mnemonic. So first, let's go over the names. Now, we can assign a specific word to each one of the cranial nerves in order to help us remember their names. So let's go through the names first of all. The first nerve is your olfactory nerve. The olfactory nerve, obviously, is for the sense of smell. The second nerve is the optic nerve. You know the optic nerve is required for vision. Cranial nerve 3 is the oculomotor. The oculomotor nerve is responsible for eye movement. Now, it's going to innervate a few specific muscles in the eye. It's going to innervate the levator palpebrae superioris, it's going to innervate the superior rectus, the medial rectus, the inferior rectus, as well as the inferior oblique. Okay, so it's responsible for quite a few movements of the eye. So just remember, oculomotor, eye movement. The fourth is the trochlear nerve. The trochlear nerve is going to innervate the superior oblique muscle. Okay, now problems with cranial nerve 4 lead to a vertical diplopia. That's most noticeable when the affected eye looks towards the nose or medially. Okay, we'll go through each one of these and give you more details. Cranial nerve 5 is the trigeminal nerve. Now, in the trigeminal nerve, we have or three branches. We have branch V1. Branch V1 is the ophthalmic branch. Branch V2 is the maxillary branch. Branch V3 is the mandibular branch. Okay, these provide sensation to the face and they innervate the muscles of mastication. Cranial nerve 6 is the abducens. Now this is going to innervate the lateral rectus muscle. That helps to abduct the eye, which is lateral movement. Now there's a way to remember the muscles of the eye because they are innervated by cranial nerves 3, 4, and 6. And the little mnemonic we put together is SO4, L6, all other 3. And what this means is that cranial nerve 4 is going to innervate the superior oblique, so SO, superior oblique, cranial nerve 4. L6 means the lateral rectus is innervated by cranial nerve 6. And all other 3 means that all the other muscles of the eye are innervated by cranial nerve 3. And we know that the oculomotor is going to innervate quite a few of these muscles here. The seventh cranial nerve is known as the facial nerve. Now the facial nerve innervates the muscles of facial expression. So anytime you see someone expressing themselves, that's cranial nerve 7 working. It also provides taste to the anterior 2/3 of the tongue. It provides secretomotor innervation to the salivary and lacrimal glands. It also innervates the posterior belly of the digastric muscle of the sapedius. The cranial nerve 8 is the vestibulocochlear nerve. Now, the vestibulocochlear nerve provides sensation of rotation and gravity, as well as sound. Now, specifically, the vestibular branches carry the impulses for equilibrium, while the cochlear branches carry the impulses for hearing. So, vestibular portions, okay, carry the impulses for equilibrium, okay, so I mean rotation, gravity, while the cochlear branches are going to help us with sound, and we'll go through the specifics of that in a few minutes. Cranial nerve 9 is known as the glossopharyngeal nerve, and this senses taste in the posterior 1/3 of tongue. Okay, it provides motor innervation to the stylopharyngeus muscle. And secretomotor innervation to the parotid gland. Now, lesions to the glossopharyngeal nerve will result in a loss of the gag reflex. Okay, that's due to afferent limb damage. Okay. It can lead to loss of sensation in the upper pharynx, loss of sensation in the posterior tongue, the tonsils, the middle ear cavity, and it can also lead to a loss of taste sensation in the posterior 1/3 of the tongue. Cranial nerve 10, this is known as the vagus nerve. The vagus nerve provides the motor innervation to most laryngeal and all pharyngeal muscles. As well as parasympathetic innervation to most abdominal and thoracic viscera, all the way to the splenic flexure. Okay, it also provides a sensation from the epiglottis. Cranial nerve 11 is your accessory nerve. This provides motor innervation to the sternocleidomastoid and the trapezius. And finally, the hypoglossal nerve. This provides motor innervation to the muscles of the tongue, all muscles except the palatal-glossus. Okay, so the hypoglossal nerve is going to be important for bolus formation and swallowing, as well as for speech articulation, because it innervates the majority of the tongue. Now, I mentioned previously how it's extremely important to remember these in the proper order, and it can be difficult to do so. So mnemonics are fantastic when it comes to the cranial nerves. Now, there's tons of mnemonics out there. There's PG rated, there's R rated, there's X rated. So use whatever mnemonic you like, whatever helps you remember. Let me give you one that is PG rated. Just in case you don't have one, you can use this. So it goes like this. On occasion, our trusty truck acts funny. Very good vehicle anyhow. So on occasion, our trusty truck acts funny. Very good vehicle anyhow. And you can see that the first letter of the nerve corresponds with the first letter of each word in the mnemonic. So if you like that one, go ahead and use it. If you don't, just Google cranial nerve mnemonics and you'll find hundreds. Okay, and pick one that works. Now, another important component of the cranial nerves is whether they are motor. So do they provide the ability to move? Are they sensory? Do they detect sensation? Or do they do both? Now, there's lots of mnemonics for determining this as well. But one of the most common mnemonics is some say marry money, but my brother says big breasts matter most. Now, if you write that out, some say marry money, but my brother says big, Now you can use big brains or big breasts, whatever helps you remember. Big brains matter most. Okay, now, like I said, there's tons of mnemonics out there, so find one that works for you. This one really works for me. I learned it once and never forgot. Now, what this means is the first letter corresponds to whether they are sensory, motor, or both. So olfactory is purely sensory. The optic is sensory because this detects smells, this detects vision. Okay, oculomotor is motor. Trochlear is motor. Trigeminal is both. Abducens is motor. The facial is both. Vestibulocochlear is sensory. The glossopharyngeal is both. The vagus is both. The accessory is motor. And the hypoglossal is motor. Okay, so these two sets of mnemonics are extremely important because you will get questions based just on that information. And if you don't use these mnemonics, you're going to have a heck of a hard time trying to remember what each one does. So instead of having to go through each component of each cranial nerve, just remember these mnemonics and you'll get some questions right. Okay, the first cranial nerve 1, is the olfactory nerve, and this is going to be responsible for detecting smells, odors, etc. The way we can test it in the clinic is to have some sort of unique smell, put it under the patient's nose with their eyes closed, and have them identify it. Okay, so some important information about the olfactory nerve is that it's located in the olfactory mucosa within the upper part of the nasal cavity. Okay, this is the shortest of all cranial nerves. And as we said, it's purely sensory. Now, damage to the olfactory nerve is very possible. Common causes include things like blunt trauma, so getting hit in the face, smashing your face against something, for example, if you're in a car accident. Cases of meningitis typically can present or have a loss of sense of smell as one of the findings. Okay. Also, specific tumors can cause a loss of sense of smell. Tumors that are located specifically in the frontal lobe. The next nerve we need to discuss is cranial nerve 2, which is the optic nerve. Now, this transmits visual information from the retina, which is at the back of the eye, to the brain. Okay. This is derived from an outpouching of the diencephalon. Now, because it's derived from an outpouching of the diencephalon during embryological development, the fibers are covered with myelin produced by oligodendrocytes. Now, this is different because other cranial nerves are covered with myelin from Schwann cells because they're peripheral nervous system structures. This is why peripheral neuropathies do not affect the optic nerve, but they can affect the other cranial nerves. Okay, so that's extremely important to remember. Based on its embryology, it won't be affected with peripheral neuropathies. Okay, don't forget, the optic nerve is also a purely sensory nerve. Next up is cranial nerve 3, which is the oculomotor nerve. Now, the oculomotor nerve is going to arise from the anterior aspect of the midbrain. And we have two nuclei for the oculomotor nerve. We have the oculomotor nucleus, okay, and we have the Edinger-Westphal nucleus. Now, the oculomotor nucleus originates at the level of the superior colliculus, and it controls the levator palpebra superioris, as well as all extraocular muscles, except for the superior oblique, and the lateral rectus. Remember, the superior oblique is cranial nerve 4, the lateral rectus is cranial nerve 6. Now, the Edinger-Westphal nucleus is going to supply parasympathetic fibers to the eye via the ciliary ganglion. That controls the pupillary sphincter muscle. That affects pupil constriction. And the ciliary muscle will affect accommodation. Okay, both parasympathetic and somatic nerve fibers are included. So when we talk about somatic nerve fibers, the somatic components innervate the inferior, superior, and medial rectus, the inferior oblique, and the levator palpebra muscles. So when paralyzed, ptosis occurs, and the down and out gaze occurs because there will be unopposed action of the lateral rectus, innervated by cranial nerve 6, and the superior oblique, which is innervated by cranial nerve 4. Now, the parasympathetic fibers, these innervate the sphincter of the iris and ciliary muscle. Now, paralysis of the parasympathetic fibers will lead to a fixed, dilated pupil, and it causes an inability of the lens to change shape, which means we have a loss of accommodation. And finally, don't forget that the oculomotor nerve is purely motor. The trochlear nerve, also known as cranial nerve 4, is fairly simple to master. It innervates the superior oblique muscle of the eye, and the superior oblique muscle is going to be responsible for moving the eye down and slightly medial. Now, cranial nerve 4 is also purely motor. Now, cranial nerve 5 is known as the trigeminal. Remember, tri means 3, and so we know there's 3 sensory branches to the trigeminal nerve. We also have motor branches. Now, because we see sensory and motor branches, we know that the trigeminal nerve is considered to be both motor as well as sensory. Now, we have 3 branches. We call them V1, V2, V3. If we look at this outline of the face here, we see the general distribution of each section or each branch. Now, V1, this is also known as the ophthalmic branch. V2, the maxillary, and V3, the mandibular. Now, V1 up here carries sensory information from the scalp and the forehead, the upper eyelid, the conjunctiva, and the cornea of the eye, as well as the nose. Now, this includes the tip, but it excludes the lower portion. Okay? And it also carries sensation from the nasal mucosa, the frontal sinuses, and the dura and blood vessels within the area. Now, here's the list. You can take a moment and write all this down. Now, V2, this branch right in here, this carries sensory information from the lower eyelid and the cheeks, the nares, the upper lip, the upper teeth and gums, the nasal mucosa, the palate and the roof of the pharynx, the maxillary, ethmoid, and sphenoid sinuses, and part of the meninges. And finally, the V3 or mandibular branch, this carries sensory information from the lower lip, the lower teeth and gums, now the chin and the jaw, except for the angle, which is supplied by C2 and C3. Okay. Parts of the external ear and parts of the meninges. It also carries touch and position and pain and temperature sensation from the mouth. It does not carry taste sensation. Now, this branch exits the skull through the foramen ovale. Now, moving on to the motor branches, these come from the mandibular nerve. So, fibers originate in the motor nucleus of the 5th cranial nerve. This is near the main trigeminal nucleus in the pons. And the motor nerves are going to control movement of 8 muscles, which include 4 for mastication. Now, these muscles include the masseter, the temporalis, the medial pterygoid, and the lateral pterygoid. These 4 muscles are our muscles of mastication, which are innervated by this motor nerve. Now, the four other muscles supplied by the mandibular nerve include the mylohyoid, the tensor veli palatini, the anterior belly of digastric, and the tensor tympani. Now, when it comes to pathology of these cranial nerves, one of the most painful pathologies is something known as trigeminal neuralgia. Trigeminal neuralgia is also known as tic douloureux. And the pain of trigeminal neuralgia often starts when someone is either eating or drinking or brushing their teeth. And the way it's described as extremely painful, shocking pain on one side of the face. So it's unilateral shocking like pain. Okay? And the cause is just a trigger of cranial nerve 5 by whatever the stimulus is. Now, the underlying pathology is not really well known. What we do know, though, is how it presents, how it feels, and that it comes in an on-again, off-again type of manner. Now, the drug of choice that we can prescribe to a patient with trigeminal neuralgia is carbamazepine. Now, carbamazepine works by inhibiting the high-frequency firing of these nerves, and it does that by reducing the ability of the sodium channels to recover from inactivation. So it slows them down so that the firing is less frequent and less intense. Now, there's some side effects associated with using carbamazepine that we absolutely must know. Now, some of the more severe ones are things like aplastic anemia. Now, whenever you see a patient taking a drug that can cause aplastic anemia, we want to always keep an eye on the blood cells. So what we're going to do is get frequent CBCs. Keep an eye on red blood cells, white blood cells, platelets, all those different types of cells. Okay. Now, carbamazepine is also an inducer of the CYP450 system. So any drug that uses the CYP450 system will be less effective when patients take carbamazepine. One of the most important drugs is warfarin. Patients take warfarin for a variety of reasons, ultimately, though, to decrease the risk of clotting. So if a patient has a high risk of clotting and they're on warfarin, and they also take carbamazepine, it's going to decrease warfarin's ability to function properly, and it increases our patient's likelihood of clotting. So always keep things like that in mind. Next up is cranial nerve 6, also known as the abducens nerve. Now, the abducens nuclei is located in the pons, on the floor of the fourth ventricle at the level of the facial colliculus. Now, the motor axons that leave this motor nucleus, they run ventrally and caudally through the pons, passing lateral to the corticospinal tract before exiting the brainstem at the pontomedullary junction. Once it leaves the pontomedullary junction, it innervates the lateral rectus. And if we're looking at an eye, we know the lateral rectus is going to attach to the lateral aspect of the eye, and when it contracts, it pulls the eye laterally. So it helps you look laterally, and that is known as abduction. And you can remember this function, abduction, because it's an abducens. Okay, so they kind of make sense. Okay, so injury to the cranial nerve 6 can cause diplopia, which is unopposed medial rectus adduction. So if this is damaged, the eye moves inward because that medial rectus is unopposed. And abducens nerve, as you might imagine, is purely motor. Next up is cranial nerve 7, which is also known as the facial nerve. Now, the big picture is that the facial nerve will emerge from the brainstem between the pons and the medulla, and it's going to control the muscles of facial expression, and it's going to provide taste sensation to the anterior 2/3 of the tongue. Okay, now the course of the facial nerve is important. The motor part arises from the facial nerve nucleus in the pons, while the sensory part arises from the nervus intermedius. Now, motor and sensory parts will enter the petrous temporal bone via the internal auditory meatus, which is close to the inner ear. It then runs in a zigzag course through the facial canal, emerging from the stylomastoid foramen and passing through the parotid gland, where it then divides into 5 major branches. Now, very important is that although it passes through the parotid gland, it doesn't actually innervate that gland. Okay? Cranial nerve 9 innervates the parotid. So that's something very important. It courses through it, but doesn't provide it with any motor or sensory innervation. Now, let's talk about the 5 major branches that you see the facial nerve divide into once it passes through the parotid gland. The first branch is the greater petrosal branch. The greater petrosal branch will provide parasympathetic innervation to the nasal gland, the palatine gland, the lacrimal gland, the pharyngeal gland. It goes to the sphenoid sinus, the frontal sinus, the maxillary sinus, the ethmoid sinus, and the nasal cavity. Second major branch is the nerve to the stapedius. Okay, now this is motor innervation to the stapedius muscle in the middle ear. Now, the stapedius helps to dampen sounds. So real loud sounds, whenever we hear something real loud, the stapedius is contracted in order to dampen the degree that we hear it by slowing or diminishing the width of oscillations. We'll talk about that in a moment in the middle ear. But when we have paralysis of the stapedius muscle or the nerve, that allows for wider oscillations of the stapes, and that leads to what is known as hyperacusis, or very loud sounds. So not only will it not dampen loud sounds, but normal sounds that aren't too loud, aren't too soft, will be heard as very loud because we don't have this dampening ability from our stapedius. So hyperacusis whenever this muscle isn't working. Then we have a branch to the chorda tympani. Okay, this branch goes to the submandibular gland, the sublingual gland, and it provides taste to the anterior 2/3 of the tongue. Okay, next up is the posterior auricular nerve. Posterior auricular nerve controls movement of some scalp muscles around the ear. And then we have a branch to the posterior digastric and stylohyoid. Now we have also 5 major facial branches that go to specific areas of the face. And if we were to look at the 5 branches as they come out of the parotid gland from top to bottom, we have the temporal branch of the facial nerve. Then we have the zygomatic branch of the facial nerve. We have a buccal branch. We have a marginal mandibular branch. We have a cervical branch. Now we'll discuss the difference between an upper motor neuron lesion and a lower motor neuron lesion and how it affects the side of the face. So what we need to realize, first of all, is that we have innervation from the corticobulbar tracts, from the contralateral side. Now, what you see here is the cranial nerve 7 nucleus. Okay, so we get supply from the corticobulbar fibers that decussates, goes to cranial 7 nucleus, and then those fibers supply the lower part of the face. Now, on that same note, we have ipsilateral fibers that do not cross over and they stay ipsilateral. So these fibers, the ipsilateral fibers, are going to supply the upper part of the face. Okay. Now, the difference between an upper motor neuron lesion and a lower motor neuron lesion is going to be the location of injury. So if we're dealing with an upper motor neuron lesion, let's say on the left side, on the right side here, so this will be your lesion. So we now have an upper motor neuron lesion, right? Upper motor neuron is above the site of the nucleus. So we're going to see it up here. So what happens is if we follow the fiber that's going to supply the face from our contralateral side, we're going to see that it travels down to the lower portion of the face. So if we break our face in half, we see that the lower portion of the face is going to be affected because this fiber will not supply that portion of the face. At the same time, we're going to notice that our ipsilateral fiber, as it went to cranial nerve 7's nucleus, and then went down and supplied the upper portion of the face, that fiber remains intact. So if we were to look at the face, you're going to see a normal eye. The nose should be fine, but you'll see a drooping of the lower portion of the face. Now, if we compare that, we see that everything on that side is fine, and on the injured side, just the lower quadrant is affected. Now that's an upper motor neuron lesion, and that's why we see sparing of the upper portion of the face, because we have ipsilateral innervation to the upper side of the face. Now, if we consider the same thing, we have our corticobulbar fibers, okay, and we maintain that ipsilateral innervation to the upper portion of the face, and we also have our contralateral innervation to the lower part of the face. But we're discussing this time a lower motor neuron lesion. Now, this means that the lesion is going to be of the facial nerve right below that cranial nerve 7 nucleus. Okay, so we have an injured cranial nerve 7. So what that means is that the innervation to the upper portion of the face in this instance will be disrupted. The innervation to the lower portion of the face in this instance will be disrupted. Now what you're going to see is a complete drooping of that side of the face. So the eye will droop, the nose will droop, and the mouth will droop. Okay, so that's the difference between an upper motor neuron lesion, right, above that cranial nerve 7 nucleus, and a lower motor neuron lesion. So if you just keep those important points in mind, that we have ipsilateral innervation to the upper portion of the face, contralateral to the lower portion, and then you just think back to where the lesion occurred, you'll be able to figure out whether or not there will be sparing of the upper portion of the face, or if there won't be sparing of the upper portion of the face. Now let's talk about cranial nerve 8, which is also known as the vestibulocochlear nerve. Now the cochlear portion of this nerve is the auditory portion. And in order for this to function, a few things have to occur simultaneously. The vestibular portion is going to sense movement. Now the vestibular portion is controlled mainly by what are known as our semicircular canals. And we'll go into each one of these parts and kind of understand exactly how they each work. So first we have to understand the bones of the middle ear, which play a role in transferring sound from the world to the inner ear. Okay, so this is the portion between the eardrum and the oval window. So if we're looking at an ear, we have our auditory canal, we have an eardrum right here. Then we have our three muscles which attach to the oval window. Okay, so the way this works is we have a malleus, an incus, and a stapes. The malleus is attached to the inner eardrum. Okay, it attaches to the incus, and that attaches to the stapes. So the incus is our middle bone, and this middle bone will attach the malleus to the stapes. Okay, the stapes is attached to the oval window. And it's going to play a main role in transmitting waves of sound to the endolymph of the inner ear. Now, there's two important muscles we need to know as it relates to these bones, and that is the stapedius muscle as well as the tensor tympani. Now, the stapedius muscle connects to the stapes, and that's controlled by cranial nerve 7. The tensor tympani muscle connects to the base of the malleus, and this is under the control of cranial nerve 5. Now, when loud sounds enter the ear, these muscles are going to contract through a mechanism known as the acoustic reflex or the tympanic reflex. And that happens in order to reduce the transmission of sound into the inner ear. So if we're asked, what does the acoustic reflex do? We can say it dampens the effect of prolonged loud noises by contracting the stapedius and the tensor tympani. That lessens the response of the ossicles to the sound, and the ossicles being our 3 bones. Now, just as a side note, there's an interesting connection that the vagus nerve has as it relates to all these structures. The posterior part of the external auditory canal is actually innervated by the small auricular branch of the vagus nerve. Okay, now the remainder and the majority of the canal is actually innervated by the mandibular branch of cranial nerve 5 via the auriculotemporal branch. Now, the inner surface of the tympanic membrane is innervated by the glossopharyngeal nerve via its tympanic branch. Okay, so the vagus does have a small role in innervating the ear. Now let's go over the cochlea. So the big picture idea of the cochlea is that its sound is going to come from the outside world, and we're going to transmit it into the cochlea, where it's going to create the sound that gets sent to the brain so that we hear. Now, step 1, sound reaches the middle ear by vibrating the tympanic membrane. Right? So then that tympanic membrane sends signals through the bones, and that is going to go to the oval window. Okay? The malleus, incus, and the stapes transmit that vibration to the oval window. Now, vibration of the oval window, what we're looking at here are the oval window and the round window. So the bones are going to vibrate this oval window here. That causes a vibration to the basilar membrane. Now, in turn, that causes bending of hair cells against the tectorial membrane. Hair cells bend, that causes oscillating hyperpolarization and depolarization of the auditory nerve, and that creates nerve impulses from sound. Well, let's take a little closer look at how this all works. So the inner ear is a fluid-filled structure that is surrounded by bone. The cochlea is cone-shaped and spirals. So if we were to take the cochlea and completely unravel it, it would make a long, straight structure. Okay, but it's actually coiled just like this. Okay, now the base of the cochlea is the widest part of the structure, and that's near the oval window right here. Okay, it's also near the round window because these are in the same location. Now this is the portion of the cochlea that recognizes higher pitched sounds. Okay, so the base hears higher pitched sounds, and that's near the oval and round windows. Okay, lower pitched sounds or lower vibrations are best heard at the apex. Now the apex is at the very end near the helicotrema. Okay, now the apex of the cochlea is at the end of the structure near the helicotrema. That's where you also find the scala tympani and the scala vestibuli, which merge together. Now, the scala tympani and vestibuli are 2 of 3 fluid-filled ducts. Now, the fluid-filled ducts are the scala vestibuli, the scala tympani, and the scala media. So if we look at the cochlea as a hemisection, we can see these three fluid-filled canals. So the superior is known as the scala vestibuli. Okay, the middle portion, this is known as the scala media. And the inferior portion is known as the scala tympani. Okay, now the scala media is separated from the scala tympani down here by a structure known as the basilar membrane. Now, the scala media and the scala vestibuli, these are separated by a structure known as Reisner's membrane. Now, the scala media is also the structure in which the organ of Corti is located. Now, that's the site that transmits sound into the nervous system. And the organ of Corti is right here. Now, the scala tympani, this one here, and the scala vestibuli, this one here, contain perilymph that is rich in sodium. The scala media, on the other hand, contains endolymph, which is high in potassium. And within the organ of Corti, we have what are known as hair cells. Now, when vibrations come in, it causes bending of hair cells against a tectorial membrane, and this leads to hyperpolarizations and depolarizations of the auditory nerve, and that creates nerve impulses from sound. Now, some people will work in environments that are extremely loud for many, many years, or some people will just listen to their music way too loud. And this can cause a problem known as noise-induced hearing loss. And you usually see this noise-induced hearing loss whenever someone's exposed to sounds for a prolonged period of time greater than 85 decibels, which you see here. Okay, so those hair cells undergo a recurring trauma, and that leads to distortion or fracturing of those cells. Okay. Now, we hear loss of high-frequency sounds first. High-frequency sounds are sounds that are greater than 4,000 hertz. Okay, so high-frequency hearing loss occurs first. Then you will see eventually the loss of low-frequency or low-vibration hearing sounds. Now let's take a look at the semicircular canals. Now we have a superior, a posterior, and a horizontal or lateral semicircular canal. So the horizontal is also known as lateral, or lateral known as horizontal. The superior semicircular canal is an anterior canal, and the posterior is obviously posterior. Now the role of these canals is to provide sensory input for rotary movements. Okay, so the anterior and the posterior semicircular canals are oriented vertically at right angles to each other. The lateral, or the horizontal, is on a 30-degree angle from the horizontal plane. Now, the lateral canal detects head movements that are lateral in nature. And if you were to stand in one spot and spin around, that would be an example of lateral movement. Now, the superior and the posterior semicircular canals, on the other hand, detect vertical head movement. So, if you were to bend forward or bend backwards, that would be an example of vertical head movement. Now, let's talk about the neurology of these canals. So, each canal is filled with endolymph and contains motion sensors within the fluid. At the base of each canal is a bony region. Now, this is enlarged and opens into the utricle, and that has a dilated sac called the ampulla. Okay. Within the ampulla is a mound of hair cells, which we see here, and some supporting cells called the crista ampullaris. Okay, the hair cells contain cilia that are embedded within a gelatinous structure called the cupula, which is right here. Okay, as the head rotates, the duct moves, but the endolymph moves a bit slower. Now that causes the deflection of the cupula and bending of the cilia within it. This bending will alter the electrical signals that are transmitted to the brain. So in situations where we accelerate in a car real fast, or we run real fast, or we make a sharp turn on an airplane, eventually you stop noticing because eventually the endolymph will catch up and the cupula is no longer affected. Now, there's a condition known as Meniere's disease, and this occurs when there's increased volume and pressure of the endolymph in the vestibular apparatus. And this is usually due to a defect in the ability to reabsorb endolymph. Now, this leads to a distension of the endolymphatic system that causes damage to the vestibular and the cochlear components of the inner ear. And this is going to be obvious by a triad of findings. Now, the triad of findings includes tinnitus, it includes vertigo, and it includes hearing loss. Now, tinnitus is ringing of the ear. Okay, patients also describe a sensation of fullness in the ear. So ringing is the main finding. Oftentimes they will complain of fullness as well. Vertigo is the sensation of motion where the room is spinning. Okay, so this is different from dizziness, because in dizziness you feel as if you are moving, whereas in vertigo the room is spinning around you. And hearing loss. The hearing loss is sensory neural. Okay, now we can determine whether hearing loss is conductive or sensory neural by performing the Rene test. Okay, we can also do this by doing the Weber test. Now the Rene test is when we check air conduction versus bone conduction. The Weber test is when we put the tuning fork in the middle of the forehead and the sound will isolate to one side. Now, it may isolate to one side if there's conductive hearing loss, or if we don't hear it in one side, that means that there's sensory neural hearing loss. And usually we want to do these together in order to get a much greater accuracy of our diagnoses. Now, let's discuss the differences between the Rene test and the Weber test. So the Rene test is going to be done to compare the perception of sound transmitted by air conduction to those transmitted by bone conduction through the mastoid bone behind the ear. So we check we put the tuning fork on the mastoid bone, and we're checking for bone conduction. And then once they don't hear it anymore, we put it next to the ear and we check for air conduction. Now this is a test for conductive hearing loss. So if we get a normal Rene test, what you're going to see is that air conduction is greater or longer than conduction through the bone. Now, if we remove the tuning fork from the mastoid process and we don't hear it anymore, we would call that an abnormal result. And in this situation, bone conductance is greater than air conductance, and that indicates conductive hearing loss. Okay? Now, if they can't hear the tuning fork on both the mastoid and the air, that indicates sensory neural hearing loss. So keep in mind, we can do this test quickly to identify conductive hearing loss, but we can also use it to recognize sensory neural hearing loss. Now the Weber test, this is a test where we put that tuning fork in the middle of the forehead. Now, if there's conductive loss, what you're going to see is that vibration isolates to the congested ear. So if we have an ear that is, let's say, full of fluid, okay, in the Weber test, the vibration will isolate to that ear. Now, if we have a patient who has sensory neural hearing loss, what happens is that the vibration will isolate to the good ear. Okay, so that's a look at your Weber and your Rene test. Now let's talk about cranial nerve number 9, which we also call the glossopharyngeal nerve. Now there's some important stuff to know about the glossopharyngeal. First, its functions. Okay, it provides sensory fibers from the tonsils, so this is sensory, from the tonsils, from the pharynx, from the middle ear, and the posterior 1/3 of the tongue. And we know that that is the taste sensation. Okay. It receives visceral sensory fibers from the carotid bodies and the carotid sinus. It supplies parasympathetic fibers to the parotid gland via the otic ganglion. Now, it provides motor fibers to the stylopharyngeus muscle. Okay, and this is the only motor component of cranial nerve 9. Now, signals for stylopharyngeus movement will be initiated in the premotor and the motor cortex. So, damage to the glossopharyngeal nerve can prevent things such as loss of taste sensation. Namely, when we're talking about loss of taste sensation, you're going to see a loss of sensation to both sour as well as bitter foods, because these receptors are most commonly or most likely located in that posterior 1/3 of the tongue. We also see loss of the gag reflex. Now let's discuss the course of the glossopharyngeal nerve. So the fibers of the glossopharyngeal nerve will leave the rostral medulla's nucleus ambiguus, and they'll travel anteriorly and laterally to exit the medulla. Now, this happens between the olive and the inferior cerebellar peduncle. It emerges from the lateral aspect of the medulla. Now, the motor component joins the other components of cranial nerve 9 to exit via the jugular foramen. Okay. The cranial nerve 9 nerve fibers travel just anteriorly to cranial nerves 10 and 11. Okay. Now, those nerves also exit through the jugular foramen. Now, upon exiting the skull, the motor fibers descend deep to the styloid process and wrap around the posterior border of the stylopharyngeus muscle before innervating it. Okay, so that's the course of the glossopharyngeal nerve. Now let's talk about cranial nerve 10. Cranial nerve 10 is also known as the vagus. Now, we have two main branches of the vagus nerve. We have the superior laryngeal branch, and we have the recurrent laryngeal branch. Now, the superior laryngeal branch is going to break into two branches. We have an external branch, and we have an internal branch. The internal branch of the superior laryngeal nerve doesn't innervate any muscles, but it provides sensory innervation above the vocal cords. Now, the only thing that the external branch of the superior laryngeal nerve is going to innervate is the cricothyroid muscle. Now, the recurrent laryngeal nerve, this is going to innervate all the laryngeal muscles except for that cricothyroid. It's also going to provide sensory innervation below the vocal cords. Now, we have a left recurrent laryngeal nerve and we have a right recurrent laryngeal nerve. And the anatomy of these nerves is important as far as which structures they go below, above, etc. So if we talk about the left-sided recurrent laryngeal nerve, this is a branch of the vagus that wraps below the aortic arch and below the ligamentum arteriosum. Okay, now the right recurrent laryngeal nerve wraps around and below the right subclavian artery. Now, whenever we damage the vagus nerve, there's a few things that we can see that are important. One important thing we see is hoarseness. Okay, so that's usually due to damage of the left recurrent laryngeal nerve. Okay, this is often a result of complications experienced during thyroid surgery. So damage to that nerve during thyroid surgery. Now, there's a condition known as Ortner syndrome. Ortner syndrome is an impingement on the left recurrent laryngeal nerve due to a dilation of the left atrium. Now, this left atrial dilation is due to mitral stenosis. So, when you see mitral stenosis, that leads to left atrial dilation, and that can impinge on the left recurrent laryngeal nerve. So you can also see hoarseness, and that's due to Ortner's syndrome. Now here's a look at the muscles of the larynx. Now, extrinsic muscles of the larynx pass between the larynx and the structures around it. The intrinsic muscles are confined entirely to the larynx. Now, intrinsic muscles are divided into two types. They're divided into respiratory and phonatory muscles. Phonatory muscles are muscles of phonation, of speaking. Now, the respiratory muscles are going to move vocal cords apart while breathing. The phonatory muscles move the vocal cords together, and they serve in the production of voice. Now, your respiratory muscles are the posterior cricoarytenoid muscles. The phonatory muscles are divided into adductors, which are the lateral cricoarytenoids and the arytenoids, and tensors, which are the cricothyroids and the thyroarytenoids. Now, remember, all muscles are innervated by the recurring laryngeal nerve, except for the cricothyroid. Okay, the cricothyroid, which you see right here, this is innervated by the external branch of the superior laryngeal nerve. Now let's talk about cranial nerve 11, which is the accessory nerve. Now, this is a purely motor nerve. Now, this innervates the sternocleidomastoid and the trapezius. Now, the trapezius is responsible for shrugging the shoulders. So testing for damage to the accessory nerve via the trapezius is very easy. You just have the patient shrug the shoulders. Okay? Injury to the accessory causes ipsilateral inability to shrug. So a right-sided accessory nerve injury will cause a right-sided problem shrugging that shoulder. Okay, so that's a very simple test we can run for that accessory nerve. Now, the sternocleidomastoid, its role is to turn the head in opposite direction. So the right-sided sternocleidomastoid role is going to be to turn the head to the left side. Now, the sternocleidomastoid, its origin is on the medial clavicle and the manubrium. Its insertion is on the mastoid process of the skull. Okay, injury to the accessory nerve will prevent rotation of the head in the opposite direction. Okay, so just as a side note, what other muscles insert on the clavicle? Okay, well, the pec major inserts on the inferior aspect, the deltoid on the inferior lateral aspect, the subclavius muscle on the inferior lateral aspect, and the trapezius on the superior lateral aspect. Okay? So it's very easy to test for an accessory nerve damage. And the last cranial nerve is cranial nerve 12, which is known as the hypoglossal nerve. Now, the hypoglossal nerve innervates the tongue, so it's going to help with food manipulation, clearing the mouth. It's also involved in the ability to properly speak or articulate. Okay, this is a purely motor nerve as well. Now, if we want to test an injury to the hypoglossal nerve, have your patient stick out the tongue. Now, there's an easy way to remember which side is injured. Whichever side the tongue sticks to is the side of injury. So if we're looking at our patient face on and we say, stick out your tongue, normally the tongue will come out straight like this. But if we have our patient stick out the tongue and it deviates, for example, to the right side, we know that we have a right-sided cranial nerve 12 injury. And the way you can remember this is that the patient is going to lick their wound. And what that means is that they're going to lick to the side of the injury or the wound. Okay? So that's a very easy way to identify which side the injury to the cranial nerve 12 is located. Now, we need to talk about schwannomas because Schwann cells are in the peripheral nerves. Oligodendrocytes are going to myelinate the CNS. So all of the cranial nerves are covered with Schwann cells except for cranial nerve 2. So that's important because we know we'll never see a schwannoma that is arising from our optic nerve. Okay. So the most common site of an intracranial schwannoma is at what is known as the cerebellopontine angle. And that's located right at cranial nerve 8. Okay. We also call these acoustic neuromas. Okay, now the acoustic neuroma usually leads to some findings like vertigo, tinnitus, and sensory neural hearing loss. Now it's important to keep in mind this looks just like Meniere's disease. So how do we identify whether it's Meniere's or if it's a schwannoma? Well, we're going to get imaging, get a CT of the head, and we'll be able to identify whether or not there's a lesion. Now, if we want to identify whether for sure this is a schwannoma in a microscopic fashion, okay, what we're going to do is look at the cells. Now, the cells are composed of spindle cells, and these are elongated, and they have regular oval nuclei. And they're also known as biphasic, which means they're highly cellular areas. Now, there's two patterns. There's Antoni A pattern or Antoni B pattern. Now, Antoni A is indicative of a highly cellular area. Antoni B, this is indicative of an area of low cellularity. Okay. Now, Antoni A areas cause or form what we call palisading patterns. Okay. And finally, we can do an immunoreactive test for detecting schwannomas. And what we're going to see is that they are what we call S100 positive. Now, this is a test to identify structures that come from a neural crest origin. And that's all that means.